Unstable angina is a change in the pattern of angina. So the patient who, let's say, again, who gets discomfort, pressure in their chest every time they walk 300 yards, but they've been that way for 2 years. Now they tell you when they see you that now I'm getting that chest discomfort at 100 yards. Or they might say, when I get chest discomfort, I take a sublingual nitroglycerin and it eases the pain. Now I'm having to take 2 or 3 of those sublingual nitroglycerins. That change in the pattern is why we call it an unstable angina. And those patients are at higher risk to go on to a heart attack. They may often have a normal physical exam, and depending on where they are and whether or not they're having occlusion or partial occlusion when you see them, the EKG may even be normal. Those who have a sudden change and then go on to actually have myocardial cell death, but their ST segment on the EKG is either normal or depressed, are said to have a non-ST segment elevation myocardial infarction. The difference between a non-ST segment elevation myocardial infarction and unstable angina is easy. It's from the lab tests. You have evidence of myocardial necrosis. Here we use troponin. Earlier in my fellowship, we used a CPK. But whatever, these myocardial cells are little powerhouses with lots of enzymes, and we detect the enzymes to tell us that there's been death of myocardial cell tissue. And then finally, on the far end of the spectrum of the acute coronary syndrome is the ST segment elevation myocardial infarction. These patients have a complete occlusion of their artery. They are often symptomatic, though not always, and the symptoms are often discomfort in the chest. I learned a lot when I was a young attending about how we need to interview our patients, because I came out of training asking patients a lot if they were having chest pain. What I've learned is that many people might feel like an elephant is sitting on their chest, but they don't perceive that as pain. So they'll look you in the eye and say, no, I'm not having chest pain. But if you ask the right question, you'll find that they are having chest discomfort. So now when I question my patients, I ask, do you have chest discomfort, pressure, tightness, squeezing, anything at all in this area that is uncomfortable? Anything in your arm, your shoulders, your back, your neck, your chin? Because that is where heart discomfort can be felt. An ST segment elevation myocardial infarction, your patients will likely have some of those symptoms. There'll be evidence later on of myocardial necrosis, and the physical exam might be normal, but it also might be abnormal, indicating that the heart is beginning to fail. And this is one way we can stratify the risk of the heart attack patient. If the heart attack is causing heart failure, an S3 gallop, elevated neck veins, crackles on lung exam, then this is a patient who's at high risk for going on to have death. And the EKG, of course, is the hallmark of the ST segment elevation myocardial infarction, with at least 2 neighboring or contiguous leads showing ST elevation of more than 1 millimeter. That is typically how we define an ST segment elevation myocardial infarction.